Hello everyone, my name is Stephanie Wu and I'm the Public Education Chair of the Scleral Lens Society. Thank you so much for joining us this evening for our free webinar on scleral lens indications. The Scleral Lens Society is proud to be offering a 4-part webinar series this year, so be sure to look out for the next webinar, which will be May 13th on scleral lens fitting basics with Dr. Michael Lipson. Be sure and also visit our website, sclerallens.org, and consider becoming a fellow of the Scleral Lens Society. If you become a fellow, your name will be listed on the practitioner website. And at this time, I'd like to introduce our presenters this evening. So first we have Dr. Melissa Barnett. She is the principal optometrist at UC Davis Eye Center in Sacramento. She serves on the board of Women of Vision and GPLI, and she is also the vice president of the Scleral Lens Society. We also have Dr. Muriel Shornack, and she practices at the Mayo Clinic and has multiple publications on scleral lenses, dry eyes, and anterior segment diseases. She is also an advisory board member of the GPLI and is the current president of the Scleral Lens Society. At this time, we'd really like to take time and thank our sponsors of the Scleral Lens Society. Without them, this webinar would not be possible. So our first platinum sponsor we'd like to highlight is AccuLens, and their lenses are the Maxim, which is the irregular scleral lens, the Comfort SL, which is for dry eye patients, and the Easy Fit, which is for normal corneas. And next we've got Paragon Vision Sciences, who creates the normalized scleral lens and also the ICD, which is irregular corneal design. Next is Visionary Optics, the creators of Jupiter, Europa, and the Alara, which is the normal cornea scleral lens. And Excel Contacts, their scleral lens is the Atlantis. And Blanchard Contact Lens, who is the creator of the One Fit for normal corneas, the One Fit Cone for early and moderate keratoconus, and the MSD, which is for irregular corneas. And last is Alden Optical, who is the creator of the Zen Lens scleral lens. And we'd also like to thank our silver and bronze sponsors. You know, all of our sponsors are very important to us and we appreciate their support. And like we said before, this webinar would not be possible without them. So thank you so much to all of our sponsors. And now the webinar will begin.
So it's Melissa Barnett here, and I want to thank you all for attending tonight's webinar, taking time out of your busy schedules to be here. We're so happy to have you. First of all, you can see our disclosures. The objectives of tonight's webinar is really to describe the use of scleral lenses in the management of ocular surface disease and also optical correction in patients with corneal irregularities. So we're just talking about all sorts of indications for scleral lenses. Nowadays, there are also indications for patients with normal corneas as well, with conditions such as astigmatism and even presbyopia. So here you can see the most recent definition of scleral lenses, and this is derived from the Scleral Lens Society. A corneal lens is a lens resting entirely on the cornea. Corneal scleral, a lens is partially on the cornea and part on the sclera. And as you can see in the scleral lens category, it is now determined by HVID, or horizontal visible iris diameter, instead of lens size. So a mini scleral lens is a lens that is up to 6 millimeters larger than the HVID, and a large scleral lens is a lens that is more than 6 millimeters larger than the HVID. And these lenses rest entirely on the sclera. So the magic of scleral lenses is really the fluid-filled reservoir that goes under the lens and over the cornea. And this corrects all the irregularities and also makes the lens very, very comfortable. We'll be talking a little bit about different lens designs, but the key point is that scleral lenses do not touch the cornea at all. They vault the cornea and land on the sclera. So it's important that the lens does not touch the cornea, that it clears the cornea completely, and also, most importantly, the limbus, because that is where limbal stem cells are derived from. And even bearing should be on the conjunctiva, so we should not see any whitening or blanching nor impingement on the conjunctiva. We are so fortunate at this point in time to have numerous scleral lens designs out there. We have many fantastic companies that have really remarkable designs, and these designs change our patients' lives. You know, that's why I do what I do, is because I can change someone's life, enabling them to see and be comfortable all day long with the use of scleral lenses. The one thing I want to highlight about the manufacturers is the consultation that they provide. So even if you're new to scleral lenses and you don't know exactly what you're seeing, calling up the consultant and saying, I see this or that, and even if you're unsure, they're extremely helpful. You can also be very specific with the consultants and say exactly what you want. Here's an example of a 5-curve lens. So you can specify the base curve, the limbal curves, the landing, the edges, different designs. You can specify toric, peripheral curves, front surface torics. There are many, many things that you can specify with different lenses, which is what I really like fitting the lenses. So the major indications of what we're talking about tonight, so for ocular surface disease, these are the patients that come in and they are miserable. So they can't function, their eyes are in pain all the time. I saw a patient yesterday and her comment was, my eyes feel like they are bathed in solution. I don't have the sensation of the air, just normal air bothering my eyes. For corneal irregularities, which we'll get to in a moment, patients like keratoconus, they cannot see as well as they'd like to with glasses, and so scleral lenses fill in all the irregularities and help improve the vision. And then what I touched on earlier was refractive correction as well. So the main contraindication for fitting scleral lenses are corneas with edema from reduced endothelial cell count, or really endothelial cell count in general. So if a patient's endothelial cell count is under 800, I say to be cautious with scleral lens fitting. So it may still be possible to fit a lens, however you may recommend a reduced wearing schedule with that lens on.
And this is Muriel Shornack speaking to you from beautiful Minnesota. Scleral shells for ocular surface disease have been described since the mid-1900s. The earliest scleral lenses were in fact scleral shells that were molded over an impression mold of the eye and could either provide ocular correction or could provide ocular surface protection. And in 1943, Klein actually described a couple of cases of scleral lenses in the treatment of what we would now call either exposure keratopathy or neurotrophic keratopathy. Ridley in 1962 described the use of his scleral shells in over 3,000 cases, and a good number of those were for ocular surface disease. Later in the 1960s, Gould described the treatment of neurotrophic keratitis in 87 cases, so we're not looking at something that's brand new here, but the concept may be old. The materials were old at that time too. Next slide, please. The earliest materials were, of course, polymethyl methacrylate in scleral lenses. And as you know, PMMA is not a great transmitter of oxygen, and so these lenses could become pretty uncomfortable pretty quickly with the lack of oxygen. Another problem is that since the plastic was molded over an impression mold of the surface of the eye, and then basically the back was carved out, these things were a little bit like snowflakes. If you got a good one once, you better keep it forever because you were never going to get another one that fit exactly the same way. Next slide, please. Rigid gas permeable lenses were first described by Don Ezekiel in 1983, talked about the use of large diameter rigid gas permeable lenses or gas permeable haptic lenses. Haptic would be a reference to the part of the lens that rested on the sclera. And Ezekiel described ocular conditions that were especially suited for haptic lenses as corneas which were disrupted, distorted, or dry due to lid deformities. In 1990, Oliver Shine, our favorite researcher of corneal ulcers with overnight contact lens wear, published a paper in which he described the use of rigid gas permeable lenses in scleral designs in 15 patients at the precursor of the Boston Foundation for Sight, and 2 of the 15 patients reported at that time were fit for ocular surface disease. And we are using a diagram on this slide from the Boston Foundation for Sight. Just wanted to make sure that we credited that appropriately. Next slide, please. But the Boston Foundation for Sight wasn't the only group who was experimenting with rigid gas permeable scleral lenses. In fact, people all over the world were taking a look at the possibility of making these lenses out of gas permeable materials. Koch was an early pioneer in the field of scleral lenses in Denmark. Ken Pullum in London was also doing a great deal of work with rigid gas permeable corneal or scleral lenses. And in 2000, Romero Rangel from the Boston Foundation for Sight published another article on gas permeable scleral lenses in the management of ocular surface disease. Next slide, please. So the rationale behind scleral lenses for ocular surface disease, if you think about it, makes sense. If the front surface of the eye is dry, the tissue that you're most concerned about is, of course, the cornea, because if that gets too dry, then you end up with persistent epithelial defects. You can end up with some stromal scarring. So you want to keep that moist. And if you hearken back to one of the slides that Melissa presented early on, you'll recall that there is a fluid reservoir that's trapped behind the lens. I tell patients it's like taking a glass of water and turning it upside down on a plate. That fluid doesn't go anywhere, although there probably is some exchange behind most scleral lenses. The other advantage is that there is absolutely no contact with corneal tissue. So if you've got a cornea with a persistent epithelial defect or even epithelium that's somewhat fragile, you are not touching the cornea, unlike any other corneal design, like a bandaged soft lens that would actually rest on that tissue and move a little bit every time the patient blinked. You're actually protecting a larger portion of the anterior surface of the eye than you would with many corneal lens designs, even soft bandage lenses. For some patients who have very disrupted tear production mechanism, covering a larger portion of the front surface of the eye equals greater relief. And there's also a potential for vision improvement, not only as the cornea heals, but also immediately. If you place a scleral lens on the surface of an eye with an epithelial defect, you will neutralize the effects of that epithelial defect on the optics of the eye by providing a new prosthetic, if you will, ocular surface. So, next slide, please. Just some general considerations when you're thinking of using scleral lenses for ocular surface disease. We're not actually curing the underlying cause of the dry eye, whatever the cause might be it Sjogren syndrome or pemphigoid, Stevens-Johnson, or anything else. We are simply providing symptomatic relief. And I like to think of scleral lenses as additive therapy. If a patient is already using lubricant drops 4 to 6 times a day and has punctal plugs and is on Restasis, I'm not going to remove the plugs, tell them never to use Restasis again, and tell them that they're no longer going to need to use lubricant drops. I'm going to simply say that the measures that we've taken so far haven't been adequate to address your issues with eye comfort, and so we're going to add scleral lenses as a next step in your therapeutic regimen. Another thing to consider is that in dry eye patients, the tears aren't sufficient to maintain a good moisture layer on the front surface of the eye. Well, those tears are not going to be sufficient to maintain a good surface on the front surface, the lens either. And so aggressively treating any meibomian gland dysfunction or any other lid disease before initiating scleral lenses would be a very good idea. And then patients do tend to get a little creative, and preserved saline is easier to find than non-preserved saline. So sometimes patients may develop a little bit of toxicity if they choose to use a preserved product in the bowl of the lens prior to application. Next slide, please. So we're going to run through a couple of cases here. The first is a 69-year-old female who has not yet had ocular surgery. She's got relatively mild meibomian gland dysfunction, slightly decreased tear meniscus, really no significant epitheliopathy, but she's severely symptomatic. Now my guess is that all of you have seen patients like this in your practice. You look at their corneas, you look at the conjunctiva, look at the lids, and things aren't pristine, but for the particular demographic, they certainly don't look dreadful either. However, this woman could hardly keep her eyes open, despite the lack of clinical signs that would have indicated severe dry eyes. She had worn a Boston Foundation for Sight, or PROS lens, from 2004 until 2009, but she lives in Minnesota, so wanted to get care a little closer to home, so came to see me in 2009. Now, of interest, her central lens thickness is greater than 300 microns, and central corneal clearance is greater than 400 microns. So if you read some of the recent literature on scleral lenses, you may be afraid to fit a lens like that, but if I could see the next slide, and you can see the next slide, despite 10 years of a very thick lens with a very generous fluid reservoir, she's done very well. She's not showing any signs of corneal hypoxia whatsoever. And I think one of the keys here is that she's wearing quite a large diameter lens. As you move towards the periphery of the lens, or as you move farther from the cornea, there is more irregularity in the sclera, and so there are pockets in which fluid exchange can occur, or through which fluid exchange can occur. And so if I dab fluorescein on the outside of her lens when she comes in to see me, within 5 to 10 blinks, that fluorescein has diffused into that post-lens fluid reservoir, and I think that's why she has maintained such good corneal health, despite the fact that she's got a rather significant lens thickness and significant fluid reservoir thickness. Next slide, please. Sjogren's syndrome is another condition that is very well treated with scleral lenses. We don't necessarily do anything different with a Sjogren's syndrome patient than we would with an undifferentiated dry eye patient, other than make sure that they are, in fact, following up with care as recommended by the rheumatologist. Now, keep in mind that many of your scleral lens patients are going to think of you as their primary eye care providers. They might not see anyone else. So if you've got somebody who is on a medication such as Plaquenil or on a medication such as prednisone, make sure that you are, in fact, following guidelines as published for management of potential complications or potential toxicity for those conditions. And in the case of Plaquenil, it would involve 10-2 visual field annually, as well as OCT, just to take a look at that inner segment, outer segment junction to make sure everything looks okay. Normally that testing is done at baseline, and then after about 5 years, beyond 5 years, this testing is to be completed annually. Moving on to our next condition, graft versus host disease. This is going to become more and more a part of your practice because increasingly stem cell transplants are being used for treatment not only of diseases such as leukemia, but also some solid organ tumors. So more patients are getting stem cell transplants, and the survival rate after stem cell transplants is getting much longer. This is actually a condition or an indication for scleral lens where that's quite well documented. Way back in 2007 in Biology of Bone Marrow Transplantation, the group from Seattle published the use of scleral lenses in their patients. The Boston Foundation for Sight also has at least one publication on this, and then we published an article on our first patients with graft versus host disease in 2008. Next slide, please. Just to give you an example of a patient with graft versus host disease, this 56-year-old Caucasian female was referred to me through our long-term follow-up clinic. This is a clinic that cares for patients after stem cell transplant. She had undergone a transplant 4 years earlier for ALL and had attempted to control her dry eye symptoms with lubricant drops, cautery, restasis, moisture chamber glasses. Vision was still quite good in the right eye. It was 20/20 in the right eye, but about 20/40 in the left eye. Now, this is a patient who had had a bad diagnosis. ALL is not something that you want to get. She had gone through the preconditioning for bone marrow transplant, which involved completely knocking out her immune system. Then she'd undergone the transplant itself, and the thing that really made her almost suicidal was the eye pain. These are patients who are going to come into you with dark glasses on, baseball caps on, and they're going to ask you to turn out the lights. They are dreadfully photophobic and terrifically uncomfortable. Next slide, please. One of the things that can sometimes show up in these patients is almost a keratinization of the palpebral conjunctiva. So you can imagine looking down at that inferior lid, that whitish, what looks like deposit is not deposit at all. It's keratin that has formed on the inside of the lid. So every time she blinked, this would rub against her cornea and give her severe pain. Of course, with the scleral lens, the cornea is now protected from that particular abrasion, and she was ever so much more comfortable. She's been wearing the lens now for approximately 4 years and is happily going on with the rest of her life, even though she has undergone rather serious treatment for a rather bad disease. Moving right along, we're going to take a look next at scleral lenses for Stevens-Johnson syndrome and TEN. Again, this indication is quite well documented. This is one of the cicatrizing conjunctivitis, and scleral lenses can provide a good deal of protection to the ocular surface in these cases too. Next slide, please. Another of the cicatrizing conjunctivitis is ocular cicatricial pemphigoid, and scleral lenses have been described in the use of in treatment for these conditions as well. Next slide, please. DART in 2005 described the use of scleral lenses in an overview paper, and we published a case report on this very case coming up next. Next slide, please. This was a 74-year-old female who had a 4-year history of eye pain and discomfort. About 2 years prior to her presentation with us, she had been diagnosed with OCP. She'd attempted both topical and systemic management, pretty much everything in the book, the normal lubricant drops, restasis, moisture chamber glasses, and still had developed significant corneal neovascularization and scarring, much worse in the left eye than the right eye. She was finally sent to me when she developed central epithelial defects, again, much worse in the left eye than the right eye. Left eye's defect was approximately 4 by 8 millimeters. Right eye's defect, when I first saw her, was about 3 by 5 millimeters. Visual acuity was 2150 in the right eye and only hand motion in the left. Next slide, please. So I don't have a picture of her when she came in, but do remember this is the right eye, and at presentation she had a rather significant epithelial defect, and you can see a bit of a scar or roughness where that epithelial defect had occurred. But after 6 weeks of therapy, that epithelial defect had closed completely, and her visual acuity had improved from 2150 to 2050. One more click will get you a closer view of that epithelium, and you'll see that it's entirely intact after just 6 weeks of therapy. And it has remained intact for 3 years following this, this fit. Next slide, please. In the left eye, we started with a much larger epithelial defect, but after 6 weeks, the epithelial defect was largely healed. Vision was hand motion. It remained hand motion. And if you click on one more, you'll see a more magnified view of that cornea. You'll see that the epithelium is intact, although not smooth. And so that's part of the reason that her vision remained at hand motion, to say nothing of the fact that she was pretty vascularized by that time. Next slide, please. Limbal stem cell deficiency can also look like cicatrizing conjunctivitis. This is a case of a 36-year-old Asian male with a 10-year history of hydrogel contact lens wear for correction of high myopia. He was about a -13 to -15, was wearing monthly replacement hydrogel lenses, and had been quite successful with them for about 8 years, but during the past several years had had waxing and waning symptoms of blurred vision, photophobia, conjunctival injection. He had been treated with doxycycline. He had tried lid hygiene, lubricant drops, decreasing contact lens wearing time, changing contact lens solution. At the time that he presented to me, his best corrected vision in the right eye was 2400. Best corrected vision in the left eye was 2050. Next slide, please. So this is what he looked like at presentation, and you'll notice that there are waves of conjunctival tissue that are or the corneal epithelium is becoming conjunctivalized. He's getting some neovascularization. There's a lot of roughness, and you can see that the eye is pretty injected. Next slide, or click again. This is what the scleral lens looked like. You'll see that there is approximately 300 microns of clearance, and that was immediately after placement of the lens. You can still see a fair amount of corneal epithelial irregularity and opacity even beneath that lens. And next click, please. This is what his eye looked like after about a month of scleral lens wear, and he's still looking just a little bit rough there, but vision had improved significantly by that time, and you'll notice that the conjunctiva is ever so much quieter. So that was the right eye. Next slide. This is what his left eye looked like at presentation, and you'll notice that the epithelium is rough, but it's not nearly as injected or as angry looking as the right eye. And next, please. This is what the lens looked like on his left eye, and you'll notice again 300 to 400 microns of clearance, a bit of inferior decentration there, but we weren't causing any epithelial or any additional epithelial compromise. And next slide, please. And this is what his eye looked like after approximately 4 to 6 weeks of scleral lens wear. So left eye really cleared up beautifully. Next slide. So 9 months after he started wearing scleral lenses, his vision had been maintained at 20/25 in the right eye because he still had a bit of residual scarring. And 20/20 in the left eye, there was absolutely no active epitheliopathy, just a little bit of corneal scarring in the right eye. And he decided that wearing scleral lenses was kind of a pain. And so he asked if he could discontinue. So in consultation with the cornea specialist who saw him at presentation, we decided to do a trial of discontinuing scleral lens wear. So followed him for about 18 months after discontinuation of scleral lens wear, had stable vision, and during that time, no recurrence of epitheliopathy. Shortly thereafter, he did develop some early epitheliopathy in the right eye, for which he wore the lenses, again for about 4 to 6 weeks. It cleared up, and he has been stable ever since. This was actually a rather interesting case for me. One would think that if someone has actually destroyed limbal stem cells, that we shouldn't be able to maintain a healthy corneal epithelium without some sort of aggressive management. But in his case, he really did heal up wonderfully. And I've had several cases with limbal stem cell, I'm now starting to call it dysfunction rather than deficiency, that when treated with scleral lenses actually seem to heal, and after some period of time find that they no longer need to wear the devices in order to maintain epithelial health. Next slide, please. Neurotrophic keratopathy is another well-documented indication for scleral lenses, dating all the way back to 1967. More recently, in 2012 and 2013 in the papers referenced on this slide. Next slide, please. So this patient is a 54-year-old female. She is a nurse practitioner, a very professional woman, had a history of herpes zoster in the left eye and subsequently developed neurotrophic keratopathy, and not necessarily a distinct defect, but just persistent punctate keratopathy that eventually led to mild diffuse stromal haze that really knocked the vision down quite a ways in that left eye. Vision at the time of presentation was 20/25 in the right eye and 2400 in the left eye. Next slide, please. And unfortunately, this patient had also a history of central serous in the right eye that then developed, oddly enough, into slowly progressive chorioretinal atrophy. So her right eye, which had been her good eye, was in the process of becoming her bad eye. So maintaining corneal clarity and vision that was as good as we could possibly maintain in the left eye was very important for this patient. So her right eye's vision has now dropped to about 20/40 at last check. Left eye's vision is holding steady at about 20/25. Now, if you look carefully, this lens shows a finding that is not at all uncommon with scleral lenses, a bit of conjunctival entrapment inferiorly. This is one of those cases where this does not seem to be a big deal. When I remove the lens, that conjunctival tissue drops right back to where it belongs, and I'm not seeing any signs of corneal changes under the area that is hooded or covered with conjunctiva. In other cases, that conjunctival tissue can actually adhere to the cornea, and it's cases where you notice that adherence that perhaps if you've got another alternative for treatment, it would be wise to pursue that. Next slide, please. Exposure keratopathy is one of my favorite things to treat with scleral lenses. If the seventh nerve is damaged, the patient doesn't have very good blink function on that time, or on that side, which of course makes it very easy for them to apply and remove lenses. Next slide, please. So this is a patient who was referred to me through our facial reanimation clinic. It's a team of providers including neurologists, plastic surgeons, oculoplastic surgeons, physical therapists that all get together to help patients who have had cranial nerve 7 palsies for whatever reason. And she had had a palsy, couldn't quite figure out exactly why. It didn't follow the characteristic pattern of a Bell's palsy. But since then, she developed a headache, eye pain, which had been worsening for 6 months prior to her presentation. She was reporting severe ocular discomfort and photophobia with the left eye, and the left eye's vision was, in fact, reduced to 20/50. Next slide, please. You'll see that when she forces a blink, she's got a decent Bell's reflex, but there was a bit of inferior epitheliopathy in that eye. She wasn't able to maintain a taped lid overnight and didn't sleep well with goggles, and so decided that a scleral lens would be the way to go, and you can see a picture of her lower with that lens in place. Now, facial asymmetry is still there. The left side of the face does not match the right side. She still can't smile, but she is one of the happiest patients that I've ever fit with a scleral lens. About every 3 or 4 months I get a rather lengthy letter from her describing how wonderful it is to wear a lens and not be in such pain continuously. Next slide, please. This is the same patient. She'd tried some bandage lenses. She'd even tried a taped-on gold weight. And next slide, please. So she experienced her comfort and relief pretty quickly. Within 2 weeks, vision was back to 20/20. The epitheliopathy had resolved. And this is one of those patients, like I mentioned before, where this scleral lens really changed her life. Even though she didn't have significant or severe ocular disease, it really made her ever so much more comfortable. She's still considering facial reanimation surgery that may help to restore some blink function and some smile function. But for right now, she's just happy that she can read the newspaper comfortably with both eyes open. Next slide, please. Next slide. Corneal dystrophy or degeneration is another indication for scleral lenses. This is probably one of the younger patients I fit with sclerals. She was 7 years old at the time I saw her. She was complaining of blurred vision, and her mom was reporting that she was rubbing her eyes continuously. She had a family history of some unspecified corneal condition that had reduced her father's visual acuity, and visual acuity at presentation was about 20/50 in the right eye and 20/80 in the left. Noticed a bunch of intraepithelial cysts on slit lamp examination, and we'll see that on the next slide, if we would. So you can see a host of little intraepithelial cysts. This child has Meesmann's corneal dystrophy. Those cysts move through the epithelium and can cause some eye irritation or pain, in addition to reducing the patient's vision. Next slide, please. So we fit her with the scleral lens, and she did very well indeed. The epithelial cysts basically disappeared. Unfortunately, she discontinued scleral lens wear once she got better, and has been a waxing and waning scleral lens wear ever since then. She's now about 14. And if any of you have 14-year-olds, you may know how difficult it is to get them to do things that would be good for them in the long run. But she's currently back on her sclerals for a brief time. I have no doubt that she'll discontinue again at some point, but she's got that tool in the toolbox for managing her condition. Next slide, please. Ocular trauma is another indication for scleral lens wear. There are folks who've undergone severe ocular trauma. This paper describes a series of 10 patients in a VA hospital who had experienced significant corneal burns, and scleral lenses were used to treat those patients. The next slide describes a case from our clinic. Next slide, please. This is a 32-year-old male with a history of left-sided facial trauma back at the age of 27 from an explosive device. He had already undergone about 15 to 20 reconstructive surgeries by the time I'd seen him. Vision was about 20/80, and that is him closing his eye. Despite all of this, he had a gold weight implanted and explanted, a bunch of lid surgery trying to get those lids into better position. He ended up with a persistent epithelial defect and was experiencing some stromal thinning that was threatening to perforate, and so he was referred to me for scleral lens fitting. The visual acuity with the scleral lens was about 20/40. Epithelial defect resolved very quickly, as is frequently the case with these patients. And the surface integrity has been maintained. He's one of the patients that I have, and I have a few who do this. They actually wear 2 scleral lenses. They've got their daytime lens and their nighttime lens. Since he can't close his eye at all, nighttime was a problem for him. So he wears one lens during the day. He removes that lens before he retires for the evening, puts the other lens on for overnight, and cleans, disinfects, and soaks the daytime lens while he's sleeping. When he awakens in the morning, he takes out his nighttime lens and exchanges it with his daytime lens. He's doing well with that regimen. Of course, we want to follow that very quickly or very closely. The last thing we want for a patient like this is to develop a corneal ulcer secondary to overnight wear of a lens. but he's doing well so far, and it is maintaining epithelial integrity. So I really do kind of think of scleral lenses as a part of stepped care, but the question is, where exactly in that stepped care does it belong? You know, the easy thing to do with patients with ocular surface disease is to try over-the-counter lubricants first, and many patients do just fine with that. If over-the-counter lubricants don't provide sufficient relief or sufficient quality of tear film, the next step would be a topical medication followed by punctal occlusion, systemic therapy, or even surgery. And the question, of course, if you'll click again, please, is where do scleral lenses fit into that regimen? Next slide, please. Just to finish up my portion, this is a chart from a study that we published in Ophthalmology earlier this year. And it takes a look at people who may do really well with scleral lenses. And those with exposure keratopathy, chronic graft versus host, refractive surgery, boy, we've got 90 to 100% maintaining scleral lens wear for anywhere from 1 to 75 months. So these patients start wearing lenses and they continue to wear them. Now, undifferentiated dry eye, and if you'll click again, we'll get a red box around that, is a different story entirely. Only about 29% of those maintain scleral lens wear beyond, for the entire period of follow-up. So even so, the average length of wear was about 10 months. So I think one could argue that these patients did experience some benefit with scleral lens wear. And that concludes my portion of the presentation. I'm going to turn it over to Melissa.
Well, thank you so much for that wonderful information. So I'm going to take a little bit of a different spin on scleral lenses and talk about corneal irregularities. And I see many, many patients every day with keratoconus that I fit with scleral lenses. Today, multiple patients. And so in these primary corneal ectasias, they have a really irregular surface, and often they're quite symptomatic. So they might have dry eye as well. They might notice glare and halos around lights, visual disturbances, especially when driving or reading, and scleral lenses can help fill in all the irregularities there. The post-refractive surgery patients, such as RK and LASIK, are also really great candidates for scleral lenses because, again, scleral lenses fill in the irregularities, and those patients may have dry eye as well, and it treats the surface. Many patients with corneal transplants are great candidates. I have a little group going of Salzman's patients that I have fit with scleral lenses, and the great thing here is that we have some newer designs where the scleral lens can actually vault over those peripheral nodules. So it's become a little bit more easy to fit the patients, although sometimes it can be a challenge. So there have been multiple publications on scleral lenses in the use of keratoconus, and I'm going to just present one of my patients here. So this was a 63-year-old male, and he was referred by a corneal specialist for scleral lens fitting or contact lens fitting in both eyes. He reported that his vision was not clear for distance, and his eyes were irritated and dry towards the end of the day. He had a history of small gas-permeable contact lens wear for many years. And the interesting thing I find here is that even after patients have been wearing these gas-permeable lenses for 40 or 50 years, they come and tell me, my eyes are not comfortable. I still feel the lenses, and I do want a more comfortable option. And that's where scleral lenses really fit in. So as you can see, his vision with his gas-permeable lenses, not horrible, 20/40 in the right, 20/25 in the left. With a manifest refraction, he is 20/60 in both eyes. And here you can see his irregular astigmatism in both eyes. So he did have meibomian gland dysfunction in both eyes, Fleischer ring, both eyes, scarring, not huge scarring, but a little bit of scarring, also some cataracts, which is something I always like to do. So to Muriel's point, it is important that all of our patients do have a comprehensive eye exam with a dilation, whether that's done with you or someone else. It is something that I like to know, especially, cataracts, which are normal age-related, to see if they have the presence of those which could affect the vision with a scleral lens. Normal pressures, normal posterior segment for this patient. So I fit him with Jupiter lenses and a 16.6 diameter. He was able to see 20/25 plus 1 in the right, 20/20 minus 2 in the left. Lenses fit well, and here you can see some pictures of the lenses on his eyes. When I saw him in follow-up, he reported some foggy vision after wearing the lenses for 4 to 5 hours. So I like to really aggressively treat any sorts of eyelid disease, and this could be with eyelid hygiene, topical eye drops, oral medications, even to the extent of changing the diet, so reducing fried and fatty foods, increasing fruits and vegetables, increasing water. I also have a patient who reported eating oatmeal for 3 months actually really helped with his foggy vision. This patient, actually, I started on Restasis, which I've found in my patient population has really shown to improve the appearance of the meibomian glands. And I'm a really big fan of non-preserved sodium chloride inhalation solution. The Soluvisc, which is a little thicker, more viscous, is helpful as well when there's any fogging because that provides more of a lubricant, and that is to be used in the bowl of the lens. Here you can see at the bottom for your reference the actual prescription of the non-preserved sodium chloride that I sent to the pharmacy, and I like to follow up with the pharmacist, either call myself or have my staff call to let them know that yes, this is correct, I do want the sodium chloride to be used with scleral lenses. So when I saw the patient back in follow-up, he reported his fogging had improved. He's now been wearing the lenses for 4 years. I saw him about a month ago. Even better vision. And now this is something I found with scleral lenses over the years is that patients with scars, the scarring does tend to improve, lessen, and patients tend to get better vision over time. Scleral lenses have also been well documented after a penetrating keratoplasty. Here you can see some references. And this is a patient of mine, a 65-year-old Caucasian male who came in and reported decreasing vision for 9 months. He had a history of prior gas-permeable contact lens intolerance, and he wanted better vision for motorcycle riding. So he also had a history of keratoconus and 2 corneal transplants in each eye. He did have a corneal transplant that was planned for the right eye and also retinal detachment in that right eye, so I fit him with the lens for the left eye only. So here you can see his irregular astigmatism. Of note is his endothelial cell count, and we're looking at the left eye, which before I told you below 800 we want to be a little concerned, and his is 716. So we'll get to that in a moment. Looking at his corneas, he did have a graft that was stable in the left eye with just a little bit of edema superiorly. He had a lot of central edema in the right eye, but again, he's going to have a transplant in that right eye. Mild cataract in the left eye, elevated intraocular pressure in that left eye, for which I sent him back to the referring doctor who was managing him and to be treated for his pressure. So I actually fit him with a prolate design for the Zen lens. So typically in a post-graft patient, you'd fit with an oblate design. However, in this particular patient, I tried the oblate design first and was just not getting an adequate fit. So it was not getting enough central clearance in their peripheral bubble. So we switched to a prolate design. And with that, he was able to see 20/20, and a very comfortable fit. It was completely clearing the cornea, the lens. He came back after 5 hours reporting foggy vision, and there's a little bit of debris under his lens. Then additional visits, he reported some pinching at 7 o'clock. So what I did is I flattened out the peripheral curves for him, and now he has good vision and comfort, does not have the pinching sensation at all, and the lens is nicely vaulting the cornea, clearing the graft completely, and he's been successfully wearing the lens for 6 months. So after his graft in the other eye, he's going to come back for a lens for the right eye as well. This is a patient of mine with glaucoma, 58-year-old Hispanic female, who came in. She was currently wearing hybrid lenses and reported irritated eyes, so she went back to a soft lens for the left eye. She reported poor vision, especially at distance when driving at night, and double vision when she was reclining or leaning back but not in straight ahead gaze. So of significance here of her ocular history is that she had a Baerveldt glaucoma implant 6 months prior to the examination in the right eye, and a right hypertropia and alternating exotropia after that implant, which is something I actually see quite often in my practice. I do work with several glaucoma specialists as well as corneal specialists where I work at UC Davis. So entering vision, 20/50, not horrible. However, as you can see here, she did have a stable glaucoma drainage device, which was located superior temporal in the right eye, and an intraocular lens in that right eye as well, mild cataracts in the left eye. She also had elevated pressures, for which I sent her back to the glaucoma specialist. She also had a history of myopic degeneration. So I fit her with scleral lenses for both eyes, wanted to keep up with the artificial tears, the omega-3s, and then sent her back to the glaucoma specialist. So for my glaucoma patient, I fit her with Maxim lenses, a 15.0 diameter in the right eye, and so I like to go a little bit smaller in these patients as to avoid the elevation on the conjunctiva. And in this case, I made a notch in the right eye, 4 millimeters, to insert superior temporal. So the important part here is not only to instruct the patient, but also whoever is training the patient on the correct orientation of the notch. And I find nowadays I am seeing more and more of these patients and fitting them successfully with scleral lenses with a notch because they do have some sort of corneal irregularity and also have had some sort of glaucoma surgery. In the left eye, I made that lens for intermediate near, a 15.4 millimeter diameter, and that was to dissociate the two eyes to eliminate the double vision. So when the patient returned, her binocular vision was 20/25 minus 2. She came in with the lens correctly positioned and did not see double vision at all. Now, the really important thing here is that in these patients, I am constantly checking their pressures every time they come in, and over 3-month visits, this is from the dispense to the check visit, her pressures were normal from 16 to 18 millimeters of mercury in each eye. So you might think, what do I do? How do I actually make this notch? And it's actually fairly simple. So first of all, you measure the size, both the height and width of the conjunctival abnormality with the slit lamp. Measure the height and width of the conjunctival abnormality while the lens is on the eye. And then this is kind of the scary part for the patient, is you take a Sharpie, and I like to tell my patients that I'm going to mark the lens and not their eye, and actually mark the scleral lens with the marker while the lens is on the eye. Then you just take the lens off the eye, measure the tracing. You could even send it to the lab if you want, and call your favorite lab consultant and discuss what you're going to do. And it's amazing how customized these lenses can become. So as was mentioned earlier, we have many fantastic companies that we work with, and I do want to thank the supporters of the Scleral Lens Society. There are some wonderful designs out there that we can use to help change our patients' lives and improve our patients' lives for the better. And now I just want to thank you for attending and open it up to questions.
Thank you, Dr. Barnett and Dr. Shornack. That was a really wonderful webinar and some really cool cases and pictures. So from the audience, we're going to take some questions, and if you look on the bottom right corner of your little application for the webinar, you'll see a little question box. And if you type in the box and submit that, then I'll be able to see it and I can ask the doctors about some of the questions that we have. So first, one of the questions that we got earlier in the webinar is, I don't know of any practice that has the ability to do an endothelial cell count, so would you consider it malpractice to be fitting these without that information? And if not, and we don't have access to that equipment, what do you suggest that we do?
I don't think it's malpractice to be fitting a lens without an endothelial cell count. Most of the patients that I fit are for corneal disease, and they're under the care of a cornea specialist in addition to seeing me for their scleral lenses, and that's an advantage that I have that I realize that you don't have in private practice. One of the signs of endothelial stress is, of course, corneal swelling. So you could potentially, if you've got a pentacam or even a pachymeter, measure the cornea before, measure corneal thickness before you begin scleral lens wear, and then periodically measure corneal thickness as a marker for endothelial cell health while the patient wears the lens. Now, keep in mind that you also have a slit lamp, and on high magnification you can get a pretty nice view of the endothelium. If it starts to look ratty or if it starts to look diseased, you may want to reconsider. Melissa, anything to add?
Yep, I completely agree with your points here. Just one more thing to add is that when seeing patients back in follow-up, to remove the lens, stain the cornea with fluorescein, use the slit lamp, and actually look for those signs of corneal edema, and that will give you an indication.
Great, thank you. Another interesting question is, I've had patients with Bell's palsy use the press and seal sandwich wrap applied to their face and lid to keep the lid closed during sleep with satisfactory results. Have you ever tried that?
My patients have, I have actually tried that, but for some reason or other they seem to want to get a lot of ointment on the eye, which then travels onto the lid, and they've had a tough time keeping it sealed overnight. But certainly I think I would prefer that if it would work, as opposed to wearing a lens full time. Another thing that I've used with some success is tranquilized goggles, and again, no financial disclosure here, but they tend to keep a pretty well lubricated or moisturized chamber in the periocular area as well. So if the patient can't stick the press and seal saran wrap to their face, then tranquilized goggles are another option.
So just another...
And Dr. Barnett,
Mm-hmm.
For the last case, what nighttime lens was used?
So in the glaucoma case, there was no nighttime lens used. So
okay,
perhaps it was referring to Dr. Shornack's last case?
Let's see. Yes, it was Dr. Shornack's last case. I'm
yes.
sorry.
Yeah, the lenses were actually identical. The daytime and nighttime lenses were exactly the same. So they were both a scleral design. And we're watching carefully. I see this patient every 3 months. And so far he's doing fine. Jennifer Sorelsky has actually published a paper that suggests that if you're going to do something like this, you should probably have the patient put a drop of Vigamox in the lens prior to application. Our cornea specialists here at Mayo are not entirely sold on that regimen simply because Vigamox is currently very effective as an antibiotic, and overuse could help it develop some resistance. So they would prefer that I not prescribe this unless there's an active epithelial defect, which this gentleman does not have. But if you've got an active defect and you think it's necessary to wear a scleral lens overnight, although I really do like the saran wrap idea much better than wearing a scleral lens. If you do determine that the scleral lens is important, then you could certainly consider that as a possibility.
And as an alternate, I have a patient who does not have an eyelid at all. And he was wearing a soft bandage lens at night, and I actually fit him with a scleral lens to see if he could eliminate the bandage soft lens. And so we tried it for a short amount of time, and just simply with lubricant ointment, he was able to eliminate the nighttime lens wear, really to my surprise. And so now it's been a few years, and he's still successfully been able to wear a scleral lens during the day, no lens at night, and just simply using lubricant ointment. But I'm also a really big fan of nighttime goggles for these patients, and even with the pads, you can heat them up and provide extra moisture at nighttime.
Very good point, Melissa.
And what are your experiences with scleral lenses in allergic conjunctivitis in children?
Melissa, go ahead.
Sure, I'll go ahead here. So really only a few cases I have of scleral lenses in children with allergies. I've had success so far. They've seen the best they've ever seen, not been symptomatic, but I really like to highlight the important things for allergies in general, which is no eye rubbing, cool compresses, refrigerated artificial tears. It is peak allergy time right now here in California, and I am seeing cases every day. But in the kids, they've done a great job handling the lenses, have obtained really good vision, and you know, a lot goes into just the training and handling with the scleral lenses.
Mm-hmm. I, too, would try a lot of other things before I would try a scleral lens for these kids. If you go to an allergist, the first thing they're going to do is tell you to control your environment. So sleep with the windows shut, run your air conditioning with a high-quality filter, cover mattresses and pillows with dust mite repelling covers. And so I kind of take the same approach with eyes. You know, certainly do everything you can first. If that absolutely doesn't work and you've got somebody who's getting, you know, corneal compromise because of papillae up under the upper lid, scleral lenses can be a great option for that. I've got a couple of patients, not necessarily children, but children and adults with severe atopic dermatitis that do well with sclerals.
And of course, you know, mast cell stabilizer, antihistamines, can't leave that out of the whole.
Absolutely not, yes.
But I think we're all just thinking that.
Mm-hmm. And I'd like to end on a question that's been asked quite frequently, and it's about extended wear or overnight wear of scleral lenses. Can you both please give us your thoughts and opinions on that?
Sure, I'll start with that.
Go ahead.
So I really like to avoid patients sleeping in their scleral lenses, and that's just in general. So I like to tell my patients not to nap in their lenses, not to sleep in their lenses, and I think the reason here is that I've just seen too many complications of patients who forgot the lenses in their eye and then they had some sort of complication after they slept in their lens. Muriel?
I use it only as a last resort. If my cornea specialist says, look, unless you can heal up this epithelial defect and keep it healed, I'm going to sew the lid shut. And I can't keep the eye moist enough with moisture chamber goggles, and I can't keep the eye moist enough. On occasion, I've used a soft bandage lens overnight with a lot of lubricant in addition to the goggles. If, despite all of that, the epithelium continues to break down overnight, I will try a short spell of overnight wear. But I don't like to consider that a long-term option. I like to consider that an option for maybe a week or two until we get that defect healed up, and then go back to daytime wear only, and maybe if we need to do something else overnight, use a soft bandage lens overnight with a lot of lubricant. So I certainly didn't mean to give anybody the impression that I do this regularly. The reason that I brought it up with the gentleman with ocular trauma is that he simply, I mean, his lower lid and his upper lid were not close to the cornea, so he was breaking down no matter what I did. But whoever asked the question about the press-on saran wrap, next time I see the patient, I may have him try that as opposed to the two lenses, because I, too, am not fond of this. I bring it up as a possibility, but only after all other options have been exhausted. Only after that cornea is going to go south regardless. You know, if we're going to sew the lid shut or do an amniotic membrane graft, if I can't get that epithelial defect closed up, and the only way I can get it closed up is overnight wear of scleral lenses, I'll do it on a limited basis, but I do not like to do it. I don't like any of my patients wearing their lenses overnight. I'm a chicken that way. I hope I clarified that sufficiently. I'm not advocating
Yes,
this at all.
thank you. Well, thank you so much, Dr. Barnett and Dr. Shornack, for such an amazing presentation. It was so informative. And thank you all for attending. If there were any unanswered questions tonight, we will try to answer them by email in the next couple days. And definitely stick around for our next webinar, which will be in May, on May 13th, and it will be on scleral lens fitting basics with Dr. Michael Lipson. So definitely don't miss that. And this webinar is recorded, so we will be able to post this on our website on sclerallens.org, and we'll be sending out an email just so that you know where to look for it. So thanks again, everybody, for attending, and we hope to see you next time. Good night.